I was asked before my main presentation to say a few words about myself, where I came from, my career development. So just a few words about myself. You probably would not recognize this fellow, but believe me, it's me. Just after graduation of the medical school. I was born and raised in Novosibirsk, Russia, middle part of Russia. And it's pretty big city like Auckland, 1.5 million people live there. And sadly enough, my interest in stroke research was triggered by the death of my father, who died at the age of 58 from stroke. And at that time, there was really no effective treatment for stroke, not even effective medication for blood pressure lowering, lipid lowering, which we all have now. And about the same time my father died, there was a big international study led by the World Health Organization called MONICA study, which is an epidemiological study of stroke and myocardial infarction, incidence, risk factors, and outcomes in 16 countries. And I was asked to join that study to look for stroke epidemiology, in particular in Siberia. So when the study was in the middle of its performance, I also received a Fogarty International Fellowship from the National Institutes of Health of the United States, and spent over 5 years working in the very famous, worldwide famous Mayo Clinic in Rochester, Minnesota. And after that, I worked in Utrecht University, Department of Neurology, and also I graduated Erasmus University with diploma in clinical epidemiology. That's briefly about myself. And now the topic of my main talk. I am giving it on behalf of my team, and the first four people, Bala, Rita, and Alex, were co-recipients of the New Zealand Prime Minister Science Prize. So I'm giving my talk on behalf of all of them. And first, what I would like to show you is a brief overview of the problem of stroke from global perspective. It is a huge problem of growing significance, growing very fast. We now have 1 in 4 people having a stroke in their lifetime. So if we have here, say, 100 people, 25 of us will have a stroke in our lifetime. So it's very significant risk. And that risk increased by 50% over the last 20 years. And another big change in the global burden of stroke is that stroke is no longer a disease of elderly. It is actually a disease of working age people, people younger than 70 years old. 63% of all people who have stroke now are people younger than 70 years old. It's a huge change. And another big change is the increase in the frequency of stroke we now have in the world. One person in the world is struck by a stroke every 3 seconds somewhere in the world. And that burden has almost doubled over the last 30 years. What is particularly worrisome is the increase in the rates of stroke or the risk of stroke in people younger than 55 years old. On this study, which was a big meta-analysis done by University of Oxford research group, they showed convincingly that in young age group there is a significant increase in the rate of stroke over the last 20 years. And you may ask why we have that huge changes in the burden of stroke in the world. One of the explanations, apart from population growth and aging of the population, is the significant increase in risk factors of stroke, particularly in young people, younger than 70 years old. I call them young people because I belong to this group. Increase in hypertension, overweight, and diabetes. These slopes are age standardized and non-age standardized, both showing a very prominent increase in the rates of the last 20 years. If you look at the projections of stroke burden in the world, we can also see that by 2050, we are expecting to have double number of deaths related to stroke, disability related to stroke, and also cost of stroke to the society. We recently estimated that by 2050, we will have $2 billion spent, $2 trillion spent every year on stroke, which is enormous economic burden to the society. Now let's take a look what we have now in New Zealand. First, I would like to show you the trend of stroke incidence we have in New Zealand over the last 40 years. As you can see, initially we have reduction in the stroke incidence, but the last decade we observed a statistically significant increase in stroke incidence for the first time in New Zealand, which is a very worrisome trend. The trend that also corresponds similar findings in other developed countries. And we now have not only 10,000 strokes, new strokes every year, but also 4,000 transit ischemic attacks, which are called minor strokes or mini strokes. About half of these people have also brain lesions, acute brain lesions related to their transit ischemic attack, are basically strokes, small strokes. And the estimated economic burden to our country is estimated about 900 million annually. Every year, society lost $900 million because of stroke. It is the cost of hospital care and cost of due to a loss of working forces, basically. The most recent Ministry of Health data in young people, people 50 to 64 years, showed significant increases in the mortality in this young age group people. And as you can see, those people, young age group people, now constitute 33% of all people having a stroke now in New Zealand, which we never had before. Most strokes used to be in this age group people over 75 years old. Now, the situation is very different, as you can see. We also have huge disparities, ethnic disparities in stroke in New Zealand. While in New Zealand Europeans, the mean age of stroke over the last 20 years is about 75 years. In Asians, it's younger, than about 8 years younger, but in Maori and Pacific people, it remains 15 years younger than in New Zealand Europeans, and it's not improving. The most recent study of outcomes of stroke by ethnicity also showed that Maori people have statistically significant worse outcome in terms of death and disability compared to New Zealand Europeans, which are shown here on the vertical reference line. So how could we handle, how we can improve the situation? The only way to reduce incidence is primary prevention. Without primary prevention, we cannot reduce incidence. We cannot reduce burden of stroke in New Zealand or internationally. Treatment can improve outcomes, but it has no effect whatsoever on the incidence. And this problem has been recognized more than 10 years ago by the United Nations resolution followed by the World Health Organization Global Action Plan on non-communicable disorders, including stroke. And those documents stated very clearly that prevention should be the mainstream all governments should be responsible for. But unfortunately, the most recent report from the United Nations showed that we are failing in achieving those goals in prevention. So now let's take a look why we are failing in stroke and also some other non-communicable disease prevention. Let's talk about strategies of stroke prevention currently available. They were all outlined very clearly for the first time by Professor Rose from Oxford University about 40 years ago. And there are two main strategies, mainstream strategies for stroke prevention. Population-wide strategy, which is undoubtedly the most effective, cost-effective, medically effective strategy for stroke prevention, which involves reduction to the exposure to risk factors across all population, regardless of the level of risk of cardiovascular disease. And one example of such strategy, which we quite successfully implemented in New Zealand, is smoking cessation campaign. We reduced smoking prevalence in New Zealand almost twice, from 30% to current 16-17%. But this is only one example of that strategy. The full population-wide strategy includes reduction of exposure to some other very important risk factors, such as sugary drinks, physical activity, increase of physical activity, low sodium or salt intake, healthy cities, improving welfare of people. These targets are quite difficult to achieve. They are costly, like reducing poverty, for example. It's a huge social task. Or they have a quite significant opposition from industry lobby, like salt reduction in the processed food or reduction of sugar in the processed food. They are not easy to be implemented, and therefore there is still no country in the world where this population-wide strategy has been implemented in full at the national level. So that's one mainstream strategy for stroke prevention and cardiovascular disease prevention. And the other strategy is the high cardiovascular risk strategy, which is also supported by the World Health Organization. You can see that heat map chart of the World Health Organization. This strategy is good in a sense that it provides a holistic, integrative approach to determining risk of cardiovascular events, including stroke. It also provides thresholds for the treatment of elevated blood pressure or blood lipids. It's also good for monitoring trends in the risk of cardiovascular events in the population. However, as any strategies, preventative strategies, it also has some minuses. And one of the main issues with this strategy is that about 80% of people are missed from this strategy because by definition it is aimed at high-risk people. But about 80% of all strokes and heart attacks develop in people with low to moderate cardiovascular risk, and they're virtually missed from that intervention. It is also quite heavily focused on the treatment, on determining thresholds for blood pressure and lipid-lowering therapy, and not focused enough on the correction of the lifestyle risk factors, except smoking, possibly. And that also gives, I would say, false reassurance to people with low to moderate risk that they are kind of protective from having myocardial infarction or stroke. And I will illustrate that disadvantage by an example in a minute. What Professor Rose wanted to show in his publication 40 years ago and later publications, what these strategies could achieve on the population level. With the high-risk strategy, he estimated that only about 15% of cardiovascular events could be prevented. And later research showed that the percentage of preventative cardiovascular events is actually far less than even that. With the population-wide strategies, which is shown on this slide by the bell-shaped curve, he wanted to achieve a shift in the distribution of risk factors, which are here, to the left. And all the people who were exposed to the risk factors in this area will not be exposed if the shift occurred. And therefore, they will be people free of those cardiovascular events. They will not develop those cardiovascular events. But what is actually preventing us in achieving those goals of shifting the distribution of risk factors to the left? One of the main obstacles is motivation. High cardiovascular preventative strategies lacking motivational tools to motivate people to change their behavior, to even follow doctors' recommendations. Without proper motivation, people will not do anything about taking medications or following healthy lifestyle, having, healthy diet and so forth. Just short counseling is not enough to change behavior and motivate people to follow those changes. So that's a big obstacle. The awareness of the population overall in New Zealand is quite low about stroke and stroke risk factors. We recently did a national-wide study looking at the awareness level, and we found that only 30% of people national-wide could name one risk factor for stroke, even one risk factor. Many people relate stroke to heart attack, to the heart, really, not to the brain. So awareness about stroke and stroke risk factors is very low, and particularly low in Maori and Pacific people. We are also lacking personalized information, information that could motivate individual, not the whole population, but the individual to change their lifestyle towards healthier lifestyle, to continue taking prescribed medications and so forth. The other obstacle, which is accessibility or affordability of prevention. It costs money to attend a GP, and GPs actually have no enough time to spend on prevention. They have 15 minutes for seeing patients who come with their own problems, not prevention. They have for different reasons. So the lacking time of clinicians is a big problem in promoting and implementing effective preventative strategies. And last but not least, there was until recently, no digital tools supporting both lay people and clinicians to know about stroke, risk factors of stroke, and how to avoid stroke. All these problems we tried to address about 12 years ago at Auckland University of Technology, and I will show you in a minute what tools we developed for that. But this is an example of how motivation is important to change behavior. Let's assume we have a person of 40 years old, obviously lacking physical activity, smoker, who has usual blood pressure of 140/90. If we apply usual cardiovascular risk calculator, in New Zealand most commonly use predict algorithm for that, a 5-year absolute risk of having cardiovascular disease for that person will be 1.6%, which is very low. And that person probably, having told that his risk is low, would probably start thinking about, even relaxing his lifestyle, eating some junk food, or not quitting smoking, not taking blood pressure lowering medications, because his risk is low. He has no motivation to change his behavior. But if we estimate his relative risk of having of stroke compared to someone of his age, sex, and ethnicity, but without additional risk factors, his relative risk is 2.4 compared to someone without additional risk factors. And that would just itself would probably motivate that person to know why his risk is increased, what risk factors account for that, and how he could reduce his risk. This is an example of only one aspect of motivation which we try to address in our research. So the situation now is that although we try to implement at the national level some population-wide preventative strategies like smoking cessation, which I mentioned, the emphasis is still on the high cardiovascular risk prevention strategy, although there is still no hard evidence from randomized controlled trial to support this strategy, to show its medical and cost effectiveness, while there are plenty of evidence that population-wide strategy is medically and cost effective. Still, the emphasis is on high cardiovascular risk strategy, and you may question why. And the answer to that question was given 15 years ago by Professor Capewell. And you can read his statement. It's just easy to report that screening is done and for policymakers to conclude that prevention is accomplished. So that's one of the main reasons we believe that this strategy is quite widely used in developed countries, including New Zealand. We are not saying that this strategy should not be used. What we try to achieve is a balance between high cardiovascular risk strategy and population-wide strategy. And for that, we need individual level prevention strategy which is applied to the individuals at any level of increased risk of cardiovascular events. Basically, making a bridge between high cardiovascular or any level of risk strategy and population-wide strategy. That's the goal. And that's what we were researching over the last 13, 14 years, and first publication was done in 2014, where we presented a new paradigm in stroke prevention using digital tool, mobile app called Stroke Riskometer app for lay people. And that followed a development of the digital tool for clinicians, which addresses all the barriers I presented you previously: motivation, personalized interventions, saving clinician times, and so forth, what I mentioned before. And I would like to show you a brief video outlining those strategies.
Stroke and other major non-communicable diseases, also known as NCDs, such as heart attacks, diabetes, dementia, chronic pulmonary disease and cancer, account for 3/4 of all deaths and over 60% of disability from all causes. Despite their profound impact and societal costs, Clinicians lack specialised digital tools for their prevention.
Most strokes and major NCDs can be prevented. Prevents MD and the Stroke Riskometer app use internationally recognized risk calculation algorithms to assist clinicians in preventing stroke and other major NCDs using tailored recommendations.
In Prevents MD, these recommendations consider the patient's risk profile, personal preferences, and clinicians' input. With several clinically tested questions and the option to automatically populate patient data, clinicians can give personalised recommendations in just a few minutes. The tool presents a visualisation of their risks over the next 5 and 10 years and their variations over time.
Prevents MD also helps clinicians to set up individually tailored, measurable, and relevant goals. These evidence-based digital tools encourage and motivate patients to make healthy, realistic lifestyle changes and improve medication adherence.
This groundbreaking, award-winning software not only allows clinicians to save time, but also to monitor patients' progress and assess the efficacy of the preventative recommendations. The software can also help policymakers advance preventative strategies and improve outcomes for stroke and other major NCDs. For further details, contact us today.
And we're currently implementing these strategies in a few large healthcare providers in New Zealand, like MedTech and Vitamata Watu Ora. Screenshots of those tools are shown here. So, unlike high cardiovascular risk strategy, we also try to develop evidence supporting effectiveness and cost effectiveness of our tools. First of all, we validated the prediction algorithm used in both Stroke Riskometer and Prevents MD softwares, and we validated it against other languages, and we showed a very high discriminative property of our algorithm compared to other commonly used predicting algorithms like Framingham stroke prediction algorithm and Q-risk. In our recent systematic review of available digital tools for primary and secondary stroke prevention, we also showed that those tools are quite unique. And we tested it about 7 years ago in a randomized controlled trial in New Zealand that showed a very high acceptability level of the tool, Stroke Riskometer app, and with the tendency to improve cardiovascular overall health as measured by special American Heart Association recommended screening called Life Simple 7. It was quite noticeably improved in people who used those tools. This change in the cardiovascular risk, though it may look small, is equivalent to 4% stroke incidence reduction at the population level, which is very clinically significant reduction of the risk of having a stroke. In a recent trial in Malaysia, there was a statistically significant improvement in the stroke risk in people who use Stroke Riskometer app compared to the control group shown here, and improve in the awareness of the stroke in people who use Stroke Riskometer app. This study is currently prepared for publication in one of the journals. In a systematic review, we found that Prevents MD and Stroke Riskometer app were only digital tools which were specifically targeted stroke prevention, primary and secondary prevention, based on reasonably good evidence and potentially globally scalable. Although there are thousands of various digital tools available for measuring various aspects of the risk and fitness, overall health fitness of the people. And among those tools with high scientific validity is currently used in New Zealand and in several other countries, predict stroke cardiovascular prediction algorithm. We also tested our digital tools, Prevents MD in particular, in 25 countries, and translated this tool in 25 languages, 5 more languages, including Maori and Pacific language, are also done and will be available very soon. This app is free to use and can be downloaded from Google Play or Apple Store and used for free. We tested usability of Prevents MD, which is a digital tool for clinicians, in 27 countries shown here on the map, using a validated system usability score. More than 80 experts were involved in these countries in testing the tool, and the usability score we obtained was very high, suggesting that clinicians will use the tool in their practice. They found value of using these tools, and on the right you can see clinical sites and experts from New Zealand involved in the testing, ranging from GPs to hospitals and universities, and different ethnic groups, servers were also involved in that testing. On top of that, we are currently doing 3 large full-scale randomized controlled trials. One large trial, about 15,000 people in Brazil, a big trial called PERCS in Australia and New Zealand. And we also recently received funding from Health Research Council to test Prevents MD and Stroke Riskometer in New Zealand. Overall, it's almost 17,000 people will be randomized in those trials, full-scale trials. We expect that they will prove the value of our digital tools beyond doubt. As was mentioned before, the digital tools has received quite significant international and national recognition, and one of them was the World Health Organization Award Bert mentioned in his introduction. It is one of the flagship projects of the World Stroke Organization, which promotes and advocates for using those digital tools in combination in population-wide strategies, with the focus on population-wide strategies shown here. As you can see, different aspects of health or factors influencing health and risk of cardiovascular events presented here, and in combination with various individual strategies, among which polypill for people with intermediate cardiovascular risk, simple screening for vascular risk factors, kind of opportunistic screening when you visit your GP. You should also ask for blood pressure testing and your weight or body mass index testing, which are very simple to measure, but they would give immediately indication whether you are at risk of having stroke or myocardial infarction or not. For more detailed understanding of the individual risk profile, World Stroke Organization recommends using a stroke riskometer app. And of course, various motivational, culturally relevant strategies for identification and management of people at any level of increased risk of cardiovascular events. And of course, using Prevents MD for clinicians. At the international level, in particularly low-middle income countries, also recommended a task shifting. And similar strategies actually taking place in New Zealand and Australia as well, when nurses or health educators take the lead in primary, particularly prevention of cardiovascular events. This reduces the workload on clinicians. They can address more aspects of secondary prevention, management issues of people who already have some cardiovascular events or at increased high risk of cardiovascular events. And that strategy is also supported by the World Stroke Organization and World Health Organization. If you recall the bell-shaped curves I presented you a few minutes ago, that the current, risk factor distribution in the population. And as I mentioned before, with high cardiovascular risk strategy, we can expect at best reduction of the incidence of cardiovascular events, including stroke, only 11% at best. If everyone in the population, say in New Zealand, is screened for cardiovascular risk, we can expect only 11% reduction. There is a good evidence from modeling studies of that. So you see, it is relatively a limited impact on the overall burden of cardiovascular events, though important, still important. What we can achieve with the population-wide strategy is up to 80% of all stroke and cardiovascular events can be prevented. This is a realistic goal, but that goal can only be achieved with the population-wide strategy when we could achieve a shift in the distribution of risk factors to the left, as I showed you in the study by Professor Rose, and all the people who remain free of exposure to risk factors will not develop cardiovascular events. And that strategy, both population-wide and high cardiovascular risk strategy, should be supplemented or enhanced by applying motivational mass prevention strategy, including digital tools I mentioned. There are also other digital tools for cardiovascular risk prediction, polypill, and task shifting, when most of the tasks in primary prevention, like patient education, informing patients, individuals about their risk, and individuals itself, they can use stroke riskometer app as an example for estimating their own risk of having a stroke in the next 5 to 10 years, and also knowing what risk factors they have and can reduce, and some strategies how to reduce those risk factors which are specific to the individual. When all these tools, digital tools, task shifting, polypill, it could add up to 50% of stroke incidence and cardiovascular disease incidence reduction. And that's eventually what we try to achieve in New Zealand and internationally. That would allow us to reduce stroke and cardiovascular disease burden quite significantly, as I showed you on this slide. Thank you for your attention.